dysplasia, which is a specific topic. Obviously, it's rare and it's uncommon conditions, but it is a condition of the dwarfing syndrome, one of the syndromes that causes dwarfism. And so we'll go through different types of skeletal dysplasias today and just talk about a little bit, mostly about the spine today. And then if people are interested, we can talk about limb lengthening and how you can lengthen people who are short stature and things like that. But for today, we'll discuss the spine. And what we have to know is that each dysplasia, each type of skeletal dysplasia, each type of dwarfing syndrome actually has its own unique characteristics. So, for instance, in achondroplasia, which is the most common form of dwarfing syndrome, you get foramen magnum stenosis, you get lumbar stenosis, and you get thoracolumbar kyphosis. And we'll discuss what that means. But in pseudoachondroplasia, it's actually nothing like achondroplasia. And then you get regular scoliosis and some instability of the cervical spine. And then there's other types such as spondyloepiphyseal dysplasia and Morequios and metatropic dysplasia. And for the reason, I'll try to go through a little bit about each one and just talk about 2 minutes perhaps about each one of these, and mainly about the spine. So achondroplasia, which is again the most common form of dwarfing syndrome, is basically the biggest problem the patients have, or the biggest problem the people have when they get older is their spine. And that's because the spine does not have room, the spinal cord does not have room in the spinal canal, in the bone, when they're formed. And that's called spinal stenosis. And scoliosis is very rare, but spinal stenosis is very common and we can treat it. Kyphosis, which means that the back is hunched over, is also very common. However, it can be avoided, and we'll talk about how to avoid that in the children in a few minutes. And this foramen magnum compression we'll talk about a little bit. So this neurologic problems in people with achondroplasia can be very slow. They can get pain when they start walking, and they do a lot of walking. And they can get these nerve root problems. They get like radiating pain down their legs, have to stop when they walk a few blocks. And if you have those symptoms, or someone with achondroplasia has those symptoms, that's a problem called spinal claudication, and that is an issue. So they have this very unusual anatomy of their spine, and I wrote it down here, short and thickened pedicles, and these are just very technical terms for why they have spinal stenosis. And almost 40 to 80% of patients, or people, between the ages of 20 and 30 will have spinal stenosis. It just shows where the spinal cord runs through, and in achondroplasia, that space is very, very small. Foramen magnum stenosis. So that's very important if you're a parent of a newborn child with achondroplasia. And the reason that's important is because that's where the spinal cord exits the brain. So basically it exits the skull. So the spinal cord comes off the brain, exits the skull into the neck, and it can cause things like apnea. They stop breathing at night. It can really cause severe paralysis in some children, and that's very rare. But we have to certainly be aware of it, and there's ways to monitor it when children are very little, and there's ways for the neurosurgeons, not myself, to treat that if it happens. But almost always, the symptoms can resolve by age 3, but they don't always resolve, and they need to be treated. And that's what it can look like, even in a 16-year-old. And for all those you can see this, there's a normal spinal cord, and right here you see that this spinal cord's been damaged because it's very, very tight as it exits the brain. What about kyphosis? What about round backs in achondroplasia? How do you avoid that? Well, one way to avoid, this is a netter picture, is not to let the children sit up very young, because they're a little bit weak, the children with achondroplasia, when they're infants. And until 18 months, you basically don't really want them to sit up fully. You can actually lean them back. And that's a really good trick to avoid kyphosis. It's called modified sitting, and Paley described this many years ago. And that's basically achondroplasia. And I'm not going to go through too much of what the x-rays look like. And there's the kyphosis, this round back. And that can increase the stenosis, and at times we need to treat it with screws. We decompress the spine, and we can straighten the spine. And that certainly can be done even in this 7-year-old boy with achondroplasia. And it can be done in adults as well who get very, very tight spinal cords. So numbness, tingling, heavy legs, making the person has to squat down, those are all signs of spinal stenosis. So for us, for instance, before we do a lengthening, before we actually lengthen someone or make them taller, we ask them, do you have weakness? Do you have problems going to the bathroom? Do you have problems limiting how far you can walk? Do you have to squat after you walk? And if they answer yes, then really an MRI has to be done, and we check that MRI because it has to be treated before you can lengthen somebody. And there's different ways of doing that in opening up the spinal canal. Okay, what about pseudoachondroplasia? How do you treat? So it looks nothing like achondroplasia. They don't look alike. The people they don't look the same, and it's not the same disease. But they, unlike achondroplasia, can get much more deformed legs. I mean, the legs can become much more bent in pseudoachondroplasia. I'm going to show that in a minute. They can get scoliosis like this picture in here, and that's just treated normally like a scoliosis you would in someone who doesn't have achondroplasia or pseudoachondroplasia. Here's a very little just knock knees. This patient was treated with just modifying the growth. So you put these little plates in, and then the legs over the years straighten out to the point where they're completely straight. And there it is. And all we did was modify the growth as the child grew. However, if you leave these to develop problems, they can develop severe deformities of the leg. And you can see here this leg is bent almost 90 degrees. And then you have to do some really creative reconstruction of the leg to fix this. And here's before, and here's after you fix that leg. So you can still fix it, but certainly you like to prevent it as opposed to fixing it in pseudoachondroplasia. So pseudoachondroplasia, we think much more about the limbs becoming bent than we think about the spine. This is called spinal epiphyseal dysplasia. They get neck problems, and they also get severe scoliosis. So we look at the neck and we treat the neck if we have to. And again, that's usually surgical. And then you have a little boy here with spinal epiphyseal dysplasia with a very severe scoliosis, and you can help them grow, and this is where I put growing rods in, those magic rods which people talk about to help them grow. And you can do that. And what about Morequio syndrome? So that's a different syndrome as well. It's associated, it can be treated now with hormone replacement, with enzyme replacement, and as well they can get other kinds of problems in their spine, like stress fractures, and also deformity, and also can become paralyzed. So in Morequio syndrome, we also treat them. So I think again, what we're trying to show is that in all of these cases, whether it's the neck in Morequios or in spinal epiphyseal dysplasia, that we know what we have to look for because we know what the diagnosis is. So I think in the skeletal dysplasia, when we're talking about the spine, we're talking about people getting scoliosis, people getting compression of the spinal cord, and people getting instability of the spine. And those three things have to be divided up. So in Morequios, they get more instability than they get scoliosis. And that instability can cause a problem. So in this patient, I stabilized her spine just to allow it to heal. Her pain went away, and her neurologic problems went away as well. And this is the follow-up of that. And you can see she also has hip problems that we treated. And this is just the last one I'll talk about today in terms of skeletal dysplasias, which is called metatropic dysplasia. It's a rare skeletal dysplasia, but has the most severe type of kyphosis. And so it needs, which is that basically that very, very rounded, hunched back. And it has certain very specific features. There can be pulmonary which are lung and cardiac problems in these patients, but they do get cervical instability, which means the neck becomes unstable and needs to be treated young. And the kyphosis, the round back they get, needs to be treated early because they can have neurologic problems. This is a very, very round back on top, and this is a case that was done, but basically you can see that you can fix this very round back in metatropic dysplasia. So I think that I've just given you just a couple of different type of spinal problems and some limb problems in skeletal dysplasia. I think that each dysplastic spine is unique, and that you have to know that when you're either have it or treating it. I think we have to be aware of the problem of that dysplastic patient because of what type of dysplasia they have. You want to treat before there are any neurologic changes, so we don't want to wait for someone with achondroplasia to become weak before we treat them, because sometimes that weakness is irreversible, which means it doesn't get better. But if you treat it early, they will get completely better. And obviously, you don't necessarily treat every deformity. It has to be progressive, and it certainly has to cause some kind of, in some cases, stenosis or some kinds of other problems. I don't think we have to be fearful of treating the very young child because they can be treated, and prevention of bigger problems. And then I just say, remember that the spine still includes the area of the spine where the skull attaches to the neck, the foramen magnum, and I think sometimes we forget this, but it is one of the big problems we see in achondroplasia, and I think that we need to understand it and evaluate it in all of our patients. So I'll end with that, just to talk for a few minutes about skeletal dysplasia, and I think maybe Michele may have some questions from people, but if there are no questions, then I can certainly, if anybody has any questions, that you could type in questions for us, and I can answer any questions regarding skeletal dysplasia or any topic about skeletal dysplasia in terms of limb deformity or spinal deformity that you may have. So I'm free to answer any questions if you have any, and if not, then we are going to sign off in about 2 minutes, and I can, if you email your questions in, we certainly can, I could email you back the answers if you don't have them right now. So we'll leave it at that today, I believe, and I'll say have a nice weekend, and this is the end of Skeletal Dysplasia for Friday with Feldman.